Good morning. Get started with our research update. A couple publications since last time. Our cases of Wassel 7 triphalangeal preaxial polydactyly got published in the Journal of Orthopedic Reports. And this is a systematic review on corticosteroid injection for carpal tunnel syndrome that I worked with Curran, Adrian, and a couple outside students with Dr. Cott on that just got published in Hand, and had some interesting findings about the rates of surgery and re-injection after carpal tunnel injections, which I'll go into more detail on research day. But the bottom line is just under half of the patients were going on to carpal tunnel release within a year, and another 30% of the patients were getting re-injected. So it seems like is a reasonable short-term solution for most people with carpal tunnel syndrome, but long-term, not a very high success rate. However, there is a very low complication rate with only 3% having minor complications and no major complications. So I think it was really good to be able to put a number on this so that you can appropriately counsel the patients when you're offering them an injection. I have a case report in progress with Amanda Gaccione that we had a patient with a proximal humerus surgical neck fracture that failed ORIF, and we converted to a nail plate combination. And then she sustained the exact same injury on the other side, and we went straight to the nail plate combo. Not a lot of descriptions of this in the literature in the upper extremity. So I think there should be a good amount of interest in this once we're done with the manuscript, which is pretty close. And then this case report on a delayed reconstruction of extensor pollicis brevis and abductor pollicis longus tendon, first dorsal compartment laceration. That we do with Dr. Belica. I'm working on this with Divya, and we're just about done, just preparing it for submission. This is the repair and the resulting function afterwards. A few additional ideas that are not officially proposals yet, but just things that I was thinking about that might be good for some junior residents if they're looking for projects, or medical students to take on. If you're interested in these ideas, you can let me know afterwards and we can talk about how to move forward. But obviously, with only a few months left, I'm not going to be able to take these all to completion. This one would be a technique review on the different ways to excise a trapezium for a CMC arthroplasty. I'm sure all of you who have rotated through hand rotations have seen a number of different ways to take out the trapezium, and some of them can be very elegant and quick in the videos you see online, and some of them can be very tedious and take a long time. So basically, I want to do a literature review and find as many described techniques for excising the trapezium as possible. And then we can get some cadaveric specimens and demonstrate some of these techniques, take photos, videos, and this could be both a technique paper. I've had some success with techniques in hand and upper extremity surgery, or a technique video for the ASSH video theater, which I've also found to be a pretty high success rate. So this would be good for another junior resident and a student to join in on. This one is one of Dr. Monica's ideas, looking at the incidence of pulmonary findings on routine pre-op CTs for shoulder arthroplasty. So depending on which system you use, most shoulder surgeons at this point are using some sort of preoperative advanced imaging for their shoulder arthroplasties, whether it's a CT or MRI. The system he uses a pre-op CT for templating, and he's noticed that a lot of these patients have incidental pulmonary findings, whether it's just nodules or, God forbid, something more aggressive. And so I think this would be a pretty simple study to go back and look at these patients, both his patients and any other surgeon who wants to join in on this, and look at how many of these patients are having pulmonary findings and what they end up leading to in terms of workup and treatment. I'm sure if anyone who has a substantial size pulmonary nodules, the radiologists are probably putting in recommendations for follow-up CTs in 6 months and stuff like that. And I'm also curious to see how many of these end up resulting in biopsies or further treatment. So Mike Simon volunteered to help with this one. I think it'd be good to have a student on board as well. This is an opportunity for a review article. I haven't really seen a review article in the literature specifically about techniques of zone 2 flexor tendon injury repair. So I think this would be a good thing for a junior resident and a student to work on together. Review papers are nice because they don't require you to get any patient data of your own. They can be a little tedious though. And for something like this, you definitely would need to make sure you're coordinating with a faculty who can advise you on which of these techniques or on the specifics of each technique. So we'd look at the clinical and biomechanical support for each of the techniques and go through venting and Wallent and all the different aspects of tendon repair that have become part of our practice. I'm very confident that this is probably already going on somewhere in the United States, but looking at the effects of Ozempic on orthopedic outcomes. So if anyone was going to take this on, you would have to do a very careful literature search and look at clinicaltrials.gov and make sure that someone isn't doing the exact same thing. But the idea would be to look at a subspecialty with a high quantity of obese patients getting surgery, which mostly spine and joints, unfortunately. And then identify patients who are on Ozempic or any of those similar drugs that have come out and compare outcomes to a control group of similar matched patients, either retrospectively or prospectively or both. So I think that this is something that is doable, but would probably take a while. I don't know exactly what percentage of our patients are on Ozempic. Not all of them are volunteering that information unless we ask. So it'd be an interesting thing to prove the concept on, but would just be careful to make sure that there's not some giant institution doing the same thing. And then this is something that I discussed with Dr. Sahabian and Dr. Teichman from the general surgery trauma team on making a multidisciplinary open fracture antibiotic prophylaxis guideline. So, at this point, the antibiotics in the ER, when we're in the trauma bay, open fractures, it's a little bit all over the place. Oftentimes we are leading the discussion in terms of which antibiotics to give and when, but oftentimes we don't get there in time for various reasons, and the trauma team gives whatever they want, or pharmacy gives whatever they want, or we'll say, pharmacy, we want to add this antibiotic, and they say no. So I think doing a complete literature review on what's out there for open fractures and antibiotics, and looking at our RWJ antibiome to see what specifically we need to protect against, and then making a guideline that has all of these different parties on board to make sure we're all on the same page. And then ideally we can collect data on open fracture patient outcomes before and after we implement whatever guideline there is. So I think there's an opportunity for this to be a QI project at Robert Wood, but I think it could also be a cohort study looking at the before and after. So that's pretty much it. Thank you. I was thinking surgery, but do you have other treatments that you're thinking of? Mm-hmm. Yeah, so I was thinking specifically like total hips, total knees, or like one level laminectomy, or non-revision case primary spine and joints. Yeah. And, we, prior to Ozempic, there was definitely a relationship between our joint surgeons and the bariatric surgeons in terms of trying to get people to lose weight before their joint replacements. And it wasn't a huge number of patients, but I think that there's probably a much larger number of patients on Ozempic than there are people getting bariatric surgery at this point. So we'll see what the numbers actually look like. Yeah. All right.
I've discussed it with anesthesia. Actually, the anesthesia has concerns about it because they tell people to be NPO after midnight, but because it results in delayed gastric emptying, they're finding that they're having more difficulty with some patients not having empty stomach when they undergo general anesthesia. So
Mm.
that may be something more acutely to be aware of rather than what the outcomes of the surgery are.
Yeah. Yeah, I'm sure, like Jared said, I'm sure there's stuff going on. Maybe there's different slants that we could take at it to make it worthwhile here, but maybe it won't be worthwhile. We'll see.
All right, good morning, everybody. I just have a few updates as well. The first one is that this ACell bladder matrix for fingertip injuries that we've been working on for a while. We had submitted our larger case series to Journal of Hand Surgery and Hand. Unfortunately, they were rejected. They didn't really leave a lot of helpful comments, which was kind of not helpful. So we submitted it to CORE and it's under review, so we're waiting to hear back from them. This other study that I presented before was evaluation of patient expectations and outcomes after distal radius fractures, where we were looking at expectations versus outcomes. And we were submitted to Hand. They sent back some comments and suggestions, which were actually helpful. And then I recently resubmitted with the revision. So hopefully we'll hear positive news from them in the upcoming weeks. And then this last study, I've been helping some of these really great medical students work on is looking at these early orthopedic exposures, focusing on the differences in between different minority groups, including race and gender. And basically, the problem or the issue that we identified or that has been identified is that there's a mismatch between the greater population, medical school matriculates, and then the representation in the orthopedic community. And we're just trying to identify different reasons why that might exist and how we can help increase the diversity in our field. So we had sent out this relatively short, easy to fill out survey, predominantly to the matched M4s and the interns of last year, to look at when people were being exposed to orthopedic surgery. And we had some pretty interesting findings. We're currently writing our manuscript, and I just have a brief overline of some of the things that we found. So we had a pretty low response rate for a survey, which I think is pretty common. 65 people responded. Granted, we're only looking at the matched M4 years and the current intern. So one thing, looking back is to expand it to a greater, more orthopedic years. Predominantly white, which is not surprising, given the fact that most of the, our field is predominantly white. And then we found that the majority of people who had successfully matched were getting exposed even before medical school, 71%, which has been shown in previous literature. And then the people who were successful, who were either women or non-whites, had much earlier experiences, which I think is important to target if we're going to try to increase the diversity in our field. A lot of minorities relied on independent searching for their exposures, which was identified as a barrier when we asked for short responses. And then, like I said, in those responses, a lot of people just said that they were having difficulties finding people in the community, someone to talk to, someone who could give them any sort of guidance on how to guide through the medical school and orthopedic application process. This is just some of the brief demographic information that I kind of already talked about in the major findings. But we have like, each of the 16 questions sort of had some interesting findings, and we're putting together our manuscript now. And kudos to the medical students who have really been working hard to get this to completion. And I think they recently got it accepted into the MSOS presentations in like April.
Anna, just one comment on that, and it was one of the few statistical significant findings we found was that participating in a research project was one of the more common ways for an underrepresented minority to get involved with the field. So it just goes to show, getting medical students involved, and, it might be a nice introduction to the department to include them on these research opportunities.
Yeah, definitely. So that was in this slide in the bottom left, I put this asterisk over it because that was a significant difference. But I mean, I think even before medical school, it sounds like a lot of people were getting their experiences even prior to medical school. So I think M1 year, and then even maybe, targeting undergrads and getting people involved into these exposures and research opportunities is really important.
Right. Good morning. A few updates. So this is our pain pump study looking at our continuous infusion pump versus single shot peripheral block. So we submitted to the IRB, and they sent back some modifications and mostly just requests for clarification. So we should have that ready to resubmit very soon, and hopefully get final IRB approval hopefully in the near future. This case report we were working on, looking at the screw back out associated with this retrograde femur nail with locking washer device. We submitted it it was presented at the Clinical Orthopedic Society meeting. It was rejected from Journal of Orthopedic Trauma, and just recently got a rejection from JBJS Case Connector. So we are currently finding another journal to submit to. Unfortunately, we didn't really get any useful feedback. Seems like, I don't think the reviewers completely understood what this implant was, and that's probably, a result of trying to format this paper to kind of fit their requirements. So we're going to work on making sure that everything is clear and submit to another journal, hopefully. Our other case report looking at early formation of a tenosynovial retinacular cyst after a trigger finger release. We've been submitting back and forth with JBJS Case Connector, and they just sent us some additional comments. So hopefully after this final revision, fingers crossed, hopefully they'll accept it. It kind of looks like it's heading that way. Our shoulder blood flow restriction study looking at the effects of BFR on rotator cuff and proximal shoulder musculature after rotator cuff repairs and arthroplasty. Currently, we're still working on enrollment at this point. And then this study that Jomar worked very hard on, looking at distal radius fracture variation in management. This was accepted to hand for publishing, and we're waiting for the proofs, and should get published pretty soon. All right. Thank you.
Morning, just a couple updates on 3 projects that have been ongoing. The first one is this utilizing video for preoperative education and meniscectomy surgery. So we finally got our IRB accepted, which is exciting. We need to film the video portion of the preoperative education, and then we need to finalize a brochure for handing out to patients at the UA offices, and then we can start enrolling patients. So the basic aims of this is that video for pre-op education in meniscectomy surgery will improve patient comprehension of operative instructions compared to a handout. And then secondarily, we're going to look at the use of opioids post-operatively. So hopefully some results in enrolling patients soon. This was a project that Eric Nussbaum worked extremely hard on. that we had some positive news on. So this is the conservative management of high ankle sprains study. We had a paper accepted at the AOSSM annual meeting that we'll do later this year in Denver. And then we also submitted a manuscript to AJSM. So we're waiting to hear back from them. And hopefully with some good news. I'll go over more of this results on Research Day, but we had some interesting statistical regression analysis from rubies, as well as a look at x-rays from 18 plus years after conservative treatment. So some interesting findings. And then this one I touched on recently in a grand rounds. It's the impact of a hip fracture protocol at a level 1 trauma center. Myself, along with Todd and Jared, as well as several medical students, worked really hard getting data from Epic on patients who underwent hip fracture surgery over about a 1.5 year timeframe since we implemented the hip fracture protocol. We have some very basic results in terms of time to surgery and hospital length of stay, but we're going to work with rubies to try to get some more analysis in terms of some secondary outcomes, including hospital costs, preoperative echoes, geriatrics consults, cardiology consults, all sorts of things that we're going to work with Kai as well, who tracks a lot of this stuff for us. So hopefully some good data coming down in the next couple months. We did get an abstract accepted at a annual trauma meeting that's in Nashville in April, and then we'll probably submit to EOA as well. So that's the update for that project. Thanks.
Good morning. Just one update. Case report started working on. It's a case I did during presentation with Dr. Bullock and Dr. Coyle. So looking at a case of a patient with bilateral atraumatic scaphoid fractures and non-unions. He had presented to the office for unrelated reason, was incidentally found to have wrist pain in both, and was found to have old scaphoid injuries on both that didn't healed. So right now, patient's still in kind of the pre-op follow-up, post-op follow-up period. We're waiting to see how he's healing. Going to get a CT before we clear him and kind of go from there. Progress on the project. So we've done working with Calvin, one of the medical students, helped us do a lot of literature search. Didn't really find many other reports in the literature of similar kind of situation. All the other ones found in the literature were all traumatic with a very obvious event, not much bilateral without a known injury. So really follow up to do is just kind of see how the patient does and kind of begin to prepare a draft for submission when kind of the follow-up period is done.
Interesting, Ben. Do we have no history of trauma? Do we know anything about this kid?
So this kid is a soccer player, but not a goalie, just a, like a forward or a midfield or something like that. He actually came to the office presenting with a mallet finger about a month prior to this complaint when he fell in an ankle sprain. Then he came for follow-up for that, began mentioning, oh, by the way, my wrists kind of hurt, and x-rays were found. And at that point, x-rays were already showing cystic changes in both scaphoids and a little bit of kind of collapse. So it was definitely not a new injury at that point, but he denied any kind of real injury. He mentioned something about catching a soccer ball, but he said that was a month ago. So it was very unclear how it happened. He denied any kind of real event. It may have been some kind of stress. The literature did reveal some found bilaterally in stress fractures in athletes, but those were all, they found them in platform divers who are like doing those handstands to, start the dive on the platform, gymnasts, or, there's one in a goalie, but this patient's not a goalie. He was 16 or 17 at time presentation. So not quite the same story as what's out there.
Interesting. Without trying to be funny, I thought you were going to say he was a skateboarder or something like that.
Oh, not quite.
Is there any
He may
language
skateboard, but-
barrier here?
The patient does speak English, but the family is predominantly Spanish only.
I've certainly had
Getting a history from a 16-year-old is notoriously difficult, and it's helpful to have input from family. I'd be curious to have, a more in-depth discussion with the parents using a really good translator to see if there's any further information that can be gleaned. Because that's just, it's hard to conceive of that. And it's cystic changes already. Obviously, it happened a long time ago. That's just, to call it atraumatic scaphoid fractures is kind of a stretch. We don't know what it was. You know what I mean?
especially in a teenager, I think. I've had this before too. Teenager came in with ulnar-sided wrist pain, ended up having bilateral scaphoid fractures. Really wasn't clear when it happened. He ran, his only sport was really track, and these kids have falls, and I would remove atraumatic from that. I would maybe say unrecognized trauma. From unrecognized trauma would make more sense, I think.
Thanks for the
Yeah,
suggestion.
I would jump on that as well. I don't know if this is a case report, but you potentially could spin it into some sort of literature review saying how often is a scaphoid non-union picked up incidentally, and then you could review, maybe the management of, when somebody comes in and they do mention wrist pain in a 16 to 18-year-old kid, it does make sense to go ahead and get a series of radiographs to potentially pick this up, because it does happen. And oftentimes they're, asymptomatic very shortly after the injury. But to bill it as a atraumatic, unless you did some sort of bone biopsy and found some sort of concomitant, medical disease or something, I think you're going to find it difficult to get that through.
$50
Appreciate it.
says mom bought him a skateboard when he was 12.
I'll check. There's no mention of that, but I'll check with Dr. Bulikich. Thank you.
Ben, do you think changing it from atraumatic to incidental, does that take away all of the buzz that it would get accepted?
Maybe a little bit, because we identified about like 26 prior reports. 21 of those were traumatic, very obvious, clear what happened. They fell, car accident, fell off a skateboard, those kinds of things. 5 of them were more stress factors and like higher level upper extremity demand athletes. But we can still definitely spin it with a more literature research. Maybe we do a more incidental, see what's the incidence of picking these up. Maybe kind of broaden our population. So it sounds like Dr. Monica has a few patients. Maybe we can ask the other hand attendings, how many they've seen. Maybe we can pull a few more patients, widen the pool a little bit. Could be an idea. Thank you.
Just for the last 2 things I would say, I've seen a fair number of, incidental scaphoid non-unions, and guys don't remember how they did it, but they've been involved in everything, mostly motocross. For some reason, those guys break their scaphoids and keep riding, and they don't come in until their thing is killing them. So, but when exactly did it happen? Did it happen when they were riding their bike? Did it happen when they were doing something else? These kids are super active, and it's hard to know where it starts from. So I agree. Incidental would be the better terminology.
Thank you.
All right, quick research updates from myself. I recently had something published from medical school, survey of postgraduate satisfaction with orthopedic residency training with some of my mentors from medical school. Got accepted and we published this year, ongoing. I have admittedly lost a little bit of steam on this project, but going to pick it back up. This is the project with Dr. Schaefer and Jason on percutaneous fixation of calcaneus fractures. We've gotten the approval for our radiation that we plan to give patients with follow-up CTs, and it's been filed as a clinical trial, but have not gotten all the way through the IRB. Still have some paperwork to do there. There's quite a few things to get a clinical trial off the ground, but we'll keep working on that. This is the study with myself and John, with Dr. Calleros. This is really being led at Brown. The outcomes of head and liner exchange in revision total hip arthroplasty, essentially looking at the outcomes depending on your approach. The data has been sent to Brown, and they are doing the analysis, and we'll be doing the write-up of that. Jeremy talked about this a little bit, the hip fracture pathway project that we're working on. So again, it was accepted to the Trauma Center Association of America in Nashville in April. I've got a case report with Dr. Bo and then the other second years and Daniel Fernandez. This is a case of a 20-year-old girl who had a compensatory scoliosis due to hypoplasia of her hemipelvis that was treated via femoral lengthening. So that has just been submitted to NJOS for now, and we need to do a little bit more of a literature review in order to submit that as a formal case report to a journal. And then there are a couple works in progress. These still need some project planning and are really not off the ground yet, but I thought were worth mentioning. Both are with Dr. Pushilin. So Dr. Pushilin really wants to do and so do I, want to do a prospective clinical trial, randomized, looking at greater trochanteric hip fractures with intertrochanteric extension on the MRI to see, can these be treated non-op? There are a few case series where these have been treated non-op. Generally here we treat them with intramedullary nail, especially if it goes beyond 50% of the way to the lesser troch. The studies that do look at it are, again, just case series, and really they're non-opping people that are not high demand in the first place, and so it's not really great data. And so he was thinking that we could probably do like a multi-center thing to get the numbers that we would need between us, Somerset, St. Peter's, and Jersey Shore. So still trying to figure that out and working with Rubies to figure out the number of patients we would need, and then also seeing if we have the retrospective data for the patients that were treated operatively to just be able to, from here on or from here forward, just treat them non-op and compare that to the retrospective cohort. But, I think we've got quite a bit more of planning to do to get that fully vetted and figured out. And then finally, this is a study that I've been wanting to do, looking at bucks versus skeletal traction on cadaveric specimens to assess just how much traction is really being generated from bucks traction. There are plenty of studies that will look at patient comfort and pain outcomes and blood loss during surgery, and it's been shown that it doesn't really matter. But there are some situations where the amount of traction that you apply matters. Like, for example, for a posterior wall acetabulum with the hip dislocation, you have to apply enough traction to keep the hip in. And so this would be a study to look at, just how much force can you really get with bucks traction, because you are going to lose some of the force through the friction with the bed from the boot. And so we're probably going to need about 10 femurs for that. I need to talk to Barb about that and figuring out exactly how we're going to measure tension, whether or not we even need to, do or need to induce a femoral shaft fracture to measure that. And then a few ideas that I have that I don't think I'm going to get around to. But,
can I ask a question? I mean, how do you account for the patient's voluntary or involuntary muscle spasm if it's a cadaveric model?
I don't think you can if it's a cadaveric model, but I don't think it's a perfect study, but I think it still tells you how much force you're generating. I mean, if there's a spasm of the soft tissue surrounding the bone, that doesn't change the amount of traction that you're applying.
I mean, it may have value, but I think that's a huge part of reductions and pulling traction is, I mean, how often do we ask, is the patient relaxed or not? Are they paralyzed? And when they're awake in traction, they're not. Something to think about.
I guess the theory of traction, though, was always that you put them in traction so you gradually overcame the spasm and it allowed them to relax. And it didn't happen immediately. It happened over time, and then sustained that traction so that you didn't have a problem. So I think computing the force applied, if the data is not out there, is a useful finding. It would be harder to apply how much do you need for, say, a hip dislocation. compared to a femur fracture, and there may be a difference in that. You'd have to, determine what the peak force applied is, and maybe you could look at as a surrogate for how much you needed to get it, reduced. Maybe it doesn't matter from a clinical standpoint, and maybe the literature already tells us that. But if we don't know what the force applied is, we maybe don't have that answer, and maybe it is different in a both column acetabulum that you're trying to get out of the pelvis temporarily compared to say a femur fracture that you're applying greater force.
I also think we're mainly just trying to figure out the difference between bucks and skeletal. I think you would still run into the issues with muscle spasms with skeletal or bucks. So while I think that is a factor, I don't know if it directly correlates to the comparison that we're trying to do. But I certainly recognize what you're talking about.
Just for a second, anecdotally, there were many fractures in the past that we couldn't get to as quickly as we get to them now. We didn't have trauma rooms and all that other stuff. And it seemed that the patients that were in this is not scientific, it seemed that the patients that were in skeletal traction were often more comfortable than those that were either not in traction or in bucks. And I'm a believer that bucks traction really doesn't do very much. The friction of the, of the leg on the bed and everything else. I mean, bucks is really not doing that much. So, I don't know. It sounds like there would be value in having that information and maybe identifying how much spasm does create pain and how much of that is, how much muscle force do you need to overcome to combat against that. They're not bad questions. It just be difficult to figure out all the answers.
I would just make sure you do a very exhaustive literature search before you venture out on this. Traction's been around for a long time. A lot of biomechanical people who like messing around with stuff like this. So I'd just make sure you really, really dive into the literature before, you don't reinvent the wheel.
Yeah, most of the searches that I've done with bucks traction, there's not really a ton on bucks traction in particular that I've seen, but it's almost all based on clinical patient comfort. And there's a study in 2012 out of Vanderbilt, which is kind of the first one that started to look at using bucks traction, or that's the kind of the main one that I've seen where they randomized it. But this is all based on kind of clinical, pain scores, blood loss, time to put the traction on. There's not really much on the biomechanics of it, but certainly worth vetting before we get 10 cadavers and start working away at it.
Well, I would go back and figure out why it's called bucks traction, because I'm sure Buck wrote a paper somewhere back there, Jared.
In the literature that there's a limitation of bucks traction, how much you can apply, especially in elderly patients who have tenuous skin. You're limited in that. The literature out there has a safe amount of skin traction, which essentially what this is, how much you can apply.
Yeah, so with that, even it seems like most of the literature is kind of, it says you shouldn't really put more than 10 pounds of weight through it, though we do that pretty frequently. And most of the data that I've seen, it kind of mentions skin traction as one of the limitations being that you can't put more than 10 pounds, but I've not been able to find a paper that has actually shown that there are actual that there is skin breakdown at greater than 10 pounds. It seems to be kind of a theoretical number, but. Thank you. And a couple ideas that I had, again, back to Bucks traction. You know, we very, very frequently put on more than 10 pounds and people do just fine within 24 to 48 hours. And so I was thinking we could even look at that and, you know, show that there haven't been many complications. Another study I've been thinking about is
Jared, have you seen any cases of skin breakdown to date?
No.
Has anybody? For Bucks traction?
that wasn't really Bucks traction. That was absolutely not Bucks traction.
I think the reason I say that is with Joe Mar's paper on the hip arthroscopy post versus postless, when you looked at things retrospectively, the incidence of complications was lower than when you looked at things prospectively. So if you actually are seeing some complications associated with Bucks traction, like there's a sense that there's complications that aren't reported or kind of blow off because they're one-offs. If you do it prospectively, you find out that they're not so rare. So that's why I'm asking. I mean, I don't have enough experience to know whether Bucks traction causes problems or not myself. If there's a sense that it's a problem, look, just monitoring it prospectively, you'll pay more attention to the potential problems. But
Another one that I was interested in. This is one that I talked about with, I think, Dr. Kirschenbaum in St. Peter's Clinic one day. It's just looking at, you know, doing like a pamphlet regarding exercises that people can do for MCP and IP joint mobility following non-operatively treated distal radius fractures, and essentially looking at like 6 weeks out when the cast comes off and then 3 months out and seeing if that makes a difference. I have an interest in delta frame configurations with single malleoli fixation that I think would be interesting. There's a case series out of Europe a year or two ago that looked at clinical outcomes based on this, but I think it'd be interesting to get the biomechanical data. That'd be hard to standardize because, you know, each ankle fracture is different. And, you know, if you've got like a big posterior mouthpiece is greater than 50%, then obviously that's going to be where your instability comes from, but we have to figure that out. We need to do the hip fracture table post guide for Guidewire video. I've got that written out. Just need to take a video of it at some point and submit that. The technique paper was accepted last year. And then there's a case report of a Downs patient with atlantoaxial instability that fell from the couch and became quadriplegic. Eventually got a C1 LAMI and then a fusion and made a full recovery that is still kind of clinically in the works. I think that the patient's still getting treated and just recently got the halo taken off, but I thought that'd be a case report too. Anyways, that's me. And for any of the med students, this is the email that I check. The last time I did this, I checked my Rutgers one like 2 months later and saw that I had blown off like 30 med students. So if you want to contact me, this is the way to do it. I promise I'm not just being a jerk by not looking treatments. All right. Thanks so much, guys.
I was gonna make one quick comment about your case report for the femoral lengthening for the hemipelvis scoliosis.
Yeah.
It may be interesting. You may get, just as a devil's advocate, you may get someone use it and asks what they look like in a seated position. So it may be interesting to post-op get a seated x-ray, right? Because if you're treating their pelvis problem with a femoral lengthening, all of the time they spend in a seated position, they still have scoliosis, correct? Yeah, so just questioning the time that you spend seated versus the time you spend standing. And I don't know what that means for the natural history. But you may come across a reviewer who says, you know, okay, what does this person look like in a seated position? Because they still have an uneven pelvis.
And are they balanced in that position? I mean, can you tell us a little bit more about this patient and why it was done, what was done?
Yeah, so it was a 19-year-old female at the time of presentation that presented to Dr. Bowe. She was being worked up by some spine surgeon in Philadelphia somewhere and was going to get a posterior spinal fusion. But in the workup of her scoliosis, it was revealed that she had a leg length discrepancy. So she followed up with Dr. Bowe. She had about a 43-degree curve, but when placing a 1-inch lift beneath the left lower extremity, it corrected to about a 23-degree curve. There was a and then they did a scanogram with a centimeter below the left lower extremity, which corrected the femoral height. So it seemed that there's somewhere in the left lower extremity, be it the femur or the tibia, there's likely a 1 centimeter leg length discrepancy, but there's still a 1.5 centimeter gap from the top of the left hemipelvis to the right. And so ultimately there was probably a combined leg length discrepancy from the hemipelvis and also the femur. And there's a discussion as whether to go trans-iliac, because it seemed like most of the deficiency was through the left hemipelvis, or to do a femoral lengthening. Obviously a femoral lengthening is a lot more, straightforward than a trans-iliac lengthening. And so they ultimately lengthened her about 25 millimeters to the left femur. And then on postoperative films, again, she corrected from about 46 degrees to about 23 degrees. She was having no symptoms from it. She was doing fine. She had no limitations. It was all cosmetic, and the patient was pleased with her cosmetic outcome. And so, she's 20 and she still needs to be followed, but it seems like she may have saved herself from a spinal fusion.
So Tim, this was not something that was undertaken, quickly. There were numerous discussions as to, the natural history of her scoliosis. Certainly, if you have a 43, 45 degree, especially thoracolumbar curve, there certainly is an incidence that this could continue to progress. She was not happy with her clinical appearance. I think that addressing her leg length, trying to balance her pelvis, certainly we have clinically improved her cosmetic appearance and her radiographic scoliosis. They know that the scoliosis might continue to get worse, but I would say that when you have a 30 to 35 degree curvature, it's far less likely that will be a significant curvature down the line than a 43 degree curvature. And plus the fact she looks a lot better. And, a lot of what we do with scoliosis is cosmetic, as you know.
Yeah. So that would have been one of my questions, is the potential for progression. And the other one would be like, where is her center line? Did it change significantly when you corrected her balance?
Well, Jared can show you that standing film. Yeah.
Yeah, that's interesting. I mean, and at 20, you wouldn't expect her to have any real progression with an otherwise stable curve, right?
True.
It's an interesting case. I would imagine that would get some pretty significant attention.
Still be curious to see her post-op seated scoli x-ray. See if she has a 47-degree curve seated.
Well, there's a post-op scoli x-ray.
In a seated position, because her pelvis is still uneven. So she's still going to have scoliosis seated.
Yeah, but you don't notice your scoliosis much, irregardless of, how large it is, whether it's, especially in a thoracolumbar, whether you are seated or standing, right, Steve? So, I mean, if you have a 45 degree thoracolumbar curvature, why do those continue to get worse into adulthood.
Yeah, no, I think it gets into the much more interesting question of the natural history. That's all, especially with leg length discrepancies and how much time we all spend standing in a perfectly kind of military position, you know, with our
But
legs.
we also don't have a seated film pre-op, and this is a contribution of both leg length and pelvis, because the pelvis is hypoplastic and that creates some sacral tilt. But you don't have a pre-op seated one, but you know what her curve looks like when she's standing. And you're right. You know, we don't spend a huge percentage of our day standing at rigid attention. I
That's a
think
huge assumption. Is that correct?
Do you stand at attention all day, Tim? I guess you do. No, I think that without a seated pre-op
about.
film, you're right. But
When
I
I'm
do
in the
think
room, Tim stands at attention.
that's the way it should be, KG. I think that I think the seated film would be interesting for the study, and I think we should get it the next time she comes in. But I do think that it'll be different because it probably was always different. But we don't have that pre-op seated film either because you don't have part of the contribution to the pelvic tilt anymore.
Exactly right.
All right. Thanks, guys.
Good morning. A few updates. So this case report that I presented last time, unfortunately was rejected. And so we are just pending resubmission to a new journal, looking for a new place to submit it. This effective Medicare versus private insurance was submitted to JSCS, and we are still waiting to get back. I'm sorry, we're pending final edits, and we should be submitting relatively shortly. Correlation of promise. This one was rejected from JSCS, but it was suggested that we transfer to a sister journal to JSCS International. So we're just making the appropriate edits and submitting to JSCS International. And this last paper was published in JSCS International. The proofs were submitted.
You did that all very fast. Very hard to know what you were putting up there.
My apologies.
What were the tibial tubercle fractures?
So it was 3 patients, and what happened was they ended up having the ORIF of their tibia, or they had a tibial tubercle osteotomy with anteromedialization. And afterwards, they ended up fracturing after greater than 3 months out. And 2 of them were fixed afterwards with an intramedullary nail, and one was utilizing ORIF, and the use of the intramedullary nail hasn't been found in the literature. So that's what we were really trying to push with this case report was.
So this was not the tubercle itself fracturing, this is the tibia fractured afterwards.
Yes, it was right at the site of the osteotomy where it fractured.
Type of fracture was it, Paul? Like a transverse?
Transverse, right where the screw was.
Because I had 2 of those, but there was a spiral fracture down the shaft of the tibia that was non-displaced. It was right at the distal extent of the osteotomy, and one guy was skateboarding and doing tricks, and the other guy was playing center field, and his tibia just cracked. So they had a stress riser because they didn't have a complete union of the very distal aspect of the tibial tubercle on the anterior cortex. I mean, everything looked like it healed. They had no pain. They were back playing fine, but they obviously developed a stress fracture right at the distal extent. So now I watch much more carefully and make sure the anterior cortex is completely healed. It's interesting that yours went through the screw hole.
It went right through the screw, and one was someone who had jumped afterwards, and another was someone who went back to, I believe, playing gymnastics and ended up refracturing.
These patients were more like 6 months to 8 months out, ones that I'm talking about.
Do you think there's any technical way to reduce this risk? Did you guys propose anything or?
Nothing that we proposed to necessarily reduce the risk. Everyone looked radiographically healed, and they didn't note any pain. They were walking around doing fine afterwards. It was just a one-time incident that seemed to have fractured them. But we thought it was an interesting way of treating it was using the intramedullary nail.
Had you removed the screws?
They did remove the screw for the one patient
So the fracture occurred with screws in place.
with the screw in place. Yep.
Interesting.
Screws
And
unicortical.
was the technique of osteotomy the same in all cases?
I believe for 2 of the osteotomies, it was the same. For the last one, it was not the same. It was a different surgeon.
Isn't there literature about technique of osteotomy and lessening the potential for pathologic or for fracture afterwards? Wasn't there something out there about that?
I would have to go and check further.
Trying to remember. I don't remember if it was the technique of the osteotomy or the fixation of the osteotomy, but I thought there was something out there about that.
I'll have to take a closer look. This paper was the effect of Medicare versus private insurance on patient-reported outcomes for total shoulder arthroplasty, using primarily PROMIS upper extremity scores, ASES and SST surveys. And we looked to see if they achieved the MCID from pre to post-operatively. And we're just pending some final edits and then submission to JSCS.
What did you find with that?
The MPID of what?
All achieved MCID and no significant difference from scores from pre to post-operatively, regardless of if they were Medicare patients or if they were private insurance patients.
And then what was do you remember what your average ages were for each of the cohorts?
The Medicare cohort was slightly older than the private insurance cohort. I believe it was 72 to in the 60s, the upper 60s, but I forget the exact difference between the two.
Okay.
And this was correlation of PROMIS upper extremity, pain interference, and pain intensity for patients undergoing total shoulder. So we were looking to see if the addition of the PROMIS pain intensity or pain interference to the PROMIS upper extremity increased the responsiveness. And we found that those that had the pain interference was a good survey to add, but the intensity was not necessarily worth adding up until the 3rd month post-operatively. And so we proposed that using this also reduce the question burden when compared to using other surveys like legacy scores like ASES, since this is a computerized model that shortens the survey process.
What is pain interference?
So it looks to see how the pain of a patient is correlated to their activities of daily living, and sees if it interferes with their ability to perform those activities. And these are all computer adaptive models. So as the patients answer the questions, based upon their answers, it'll either pop in more questions or close out the survey sooner so that they're not getting repeated questions, which decreases survey burden, which a lot of patients are experiencing with all these patient-reported outcome measures. And the last was looking at the analysis of factors associated with patient-reported outcome scores after 1 year from shoulder surgeries. And it was finally published in JSCS International, but primarily it showed that those that were of younger age were less likely to complete these patient-reported outcomes, and those that were male were less likely to complete them. So our hypothesis, because these, or our theory and part of the discussion, because we had completed these a lot with email, was that for those patients, it would be better suited to collect these reported outcomes when they come to the office, and try maybe while they're waiting in the waiting room to give them the patient reported outcome scores, as opposed to sending them to them via email, since they most likely will not get completed. Thank you.
And that's kind of interesting because I would have just guessed that young people with they're communicating via email, not text or anything like that.
I'm sorry?
They're not communicating via text for
So
the patient reported outcomes. It was only email.
The surveys were sent out via email at predetermined time points of preoperatively, then 2 weeks. 2 weeks, 6 weeks, 3 months, 6 months, and a year. And they didn't send any by text, but that may have been an interesting way to do it. We also tried calling them telephonically, but a lot of patients either they don't pick up or they're busy during the day.
Yeah, that's not happening.
via telephone.
Because we have started with the CareSense in our practice, and the communication is via text. And we're also, it's challenging to get people to reply no matter what you do, but I think text for especially the younger patients may be a better way to go, since they may not even look at their emails often as they look at their text messages. And I just had, we're now collecting, we're out past 1 year since CareSense has been up and running, and we're starting to see some pretty good responses, but I obviously you didn't use it, so you can't say anything about it unless that's like a conclusion of the paper.
But a lot of the literature that's out there looks at surveys that are sent, just mass surveys that are sent out to patients that come for an experience, or they come to the a hospital, I'm sorry, and then they send these surveys. But all these patients had they acknowledged that they were enrolled in the study. They said they wanted to be enrolled. And then we were looking at who, with knowledge of being enrolled in the study, doesn't respond, as opposed to those, a lot of the surveys are just sent out as a blanket survey.
And it tails off as time goes on.
It does.
Like even in our experience, we're seeing 80 to 90% response rate for pre-op scores. We're seeing 80% at 3 months. And then we start to see 70 or 60% at 6 months, and 50 or 60% at, but I think we're doing better than that. But one of the things that Eric Nussbaum got me to do, which I've been doing on a regular basis, is I review the patient reported outcomes scores with the patients post-operatively. Like I just show them what they've entered, and then it kind of incentivizes them to fill out the next one, which they might want to blow off as they're feeling better. Hopefully they're feeling better and not worry about it. So it's interesting concept of how to get people to reply. You'd like to say you can get 80% response rate, but that's shooting for a very high return rate.
Yes.
Before everyone hangs up, I know there's a couple of upper extremity people on the Zoom call, so I'm going to make a plug for 2 of the prospective studies that are running. Dan talked about one, which is BFR as part of post-op rehab for rotator cuff repairs, and another one, which IRB approval should be obtained very shortly, which would be prehab for rotator cuff repair. Both of these are randomized prospective studies looking at patient-reported outcomes. And one of our challenges that we've dealt with as part of the sports medicine research group is trying to enroll patients in the studies. A lot of work has gone on to create well-designed studies. Our PT departments at all of the offices have bought into these studies. We have, microfet devices so we can quantitatively assess strength and things like that. I think they're very well-designed studies. We're doing surgery, but we have to get patients enrolled in these studies. So for people that are on this research update and doing rotator cuff surgery, please try to think about these things when you're booking patients for surgery.
I was going to make mention of one other study too, because I don't think Rob Dow officially handed over the Scoli-Epi study because it's still ongoing. So the effective epinephrine for reducing blood loss. And we're just, I want to say we're just about the halfway mark for enrolling. We're trying to enroll 40 patients, and it's a level 1 prospective randomized controlled trial. So I think it would be perfect for probably a junior resident. So maybe someone who's like a PGY2-ish, only because our hopes would be to maybe with this Scoli season and summer, and then next Scoli season and summer to hopefully hit the 40 mark. And then I think you would still have your 4th year, 5th year, whatever, to actually do the kind of data. But it'd be a great way to publish a level 1, study. So I'm definitely looking for a junior.
Hey,
Steve, what
Charlie,
do
is
you
there
mean
a
by-
criteria besides? Sorry, go ahead.
I don't know the term Scoli season. It's a seasonal thing? That's new.
Surgically, classically, yes, it is for May, June, July seems to be the Scoli season, so kids don't miss as much school.
Yeah, no, okay, understood. Thanks.
It
Hopefully,
correlates with the first.
Charlie, is there a
birthday
criteria for the
academic
size?
year. Tim?
Sorry, I was just asking if there was a criteria for size of rotator cuff tear, or shape of rotator cuff tear in the prehab study? Does it have to be a small tear? Can it be any size tear? Does it have to be full thickness? Can it be partial thickness? Is there anything in there for that?
It's all full thickness tears for the prehab study.
Any size, any size? Okay,
Yes.
thank you.
And what's the best way to enroll the patients, Charlie?
So physical therapy knows about it, and technically, as participants in the study, we're not supposed to obtain the consent for the procedure, but you, like we have those brochures, and we don't have the prehab one yet, but I think it'll be ready shortly. And what I'm doing is I'm giving the patients a brochure and saying, discuss this with physical therapy, but to participate in the study, they have to do therapy at one of our offices. So the physical therapists are actually enrolling the patients in the study.
And so then they have to meet with the therapist before surgery.
Yeah, because if you want to do prehab, I don't think we routinely prescribe therapy before rotator cuff surgery, but several of our therapists think it would be beneficial, and it certainly has borne out that that's the case for ACL surgery.
I do it all the time, frankly, in patients with, non-traumatic tears, chronic tears of the rotator cuff. I don't know how long they've been there. I think many of them, a certain percentage of them are going to prehab and not need to have surgery. And I think the ones that do prehab, in my experience, anecdotally, is that they do better post-operatively, but that's purely anecdotal.
So the ones that, if you're just saying you have a rotator cuff tear, and I'm going to see if we can get you better without surgery, that's not the enrollment criteria. It's somebody who's booked for surgery. Usually to get on your surgery schedule, you're probably looking at 3 weeks or so. And so, doing as a few visits of prehab prior to surgical intervention, that's what we're really trying to look at.
Okay.
We can discuss it at a partner meeting as well, because I think it is something, we had a big office meeting where I spoke with everybody in the office, PAAs, PT, the PAs and the nurses who are, room the patients. So we're trying to get everybody on board. So we're constantly reminding patients that we have these studies going on. And if I know if you're in the room, you'll see that we have the running slideshow going now, which introduces all of our research projects to patients. Disappointingly to me, when I walk into the room, the slideshow's running and their faces in their cell phone, and they're not watching the slideshow. So I was rather disappointed about the effort we put into that. We worked hard to make a nice slideshow, but I guess there's more interesting things on their personal cell phones. Maybe we have to put some sound effects on it as well.
Are there any issues with insurances paying for prehab if patients already did a full course? Are there any issues with insurance paying for prehab if they already did a full course of PT before they signed up for surgery?
No, because it just continued as regular physical therapy. It's not a different type of physical therapy.
So they can be included if they had therapy beforehand as well, or
Yeah,
only people?
Yes.
Okay. And so is the prehab as like a specific regimen that they're putting them through? Like it's
Yes, it is.
okay.
So this is like akin to prehab for ACLs?
Correct.
Okay.
Got it.
But again, we are 99% sure we're awaiting IRB on that, but I know we're very close. Mike Simon, who's not here today, has done a lot of work on that project and done a very good job. And some students who may be in the room, and if you are, you can raise your hand, but I think that's where we stand. Yeah, that's a good point. Dr. Malberg pointed out that should give us enough time to do prehab. All right, thanks, everybody. Good work by everyone.
How are you? Good.